Hi, this is Jamie from the Siskiyou Family YMCA. Welcome to Wellness Wednesday, Pelvic Health. Everything you should know, but we're afraid to ask. In this conversation today, we will be using some anatomy that may not be suitable for young children, so please use care when listening. Lauralee Wallace is a physical therapist and she's been practicing for over 30 years. And for the last year, she has been specializing in pelvic floor therapy. She has her own personal story that really adds to the presentation. Enjoy.
So thank you for coming, because we're going to use words today that we're not all comfortable saying. Just a little bit about me. I started working in physical therapy at UC Davis Medical Center back in 1989. I worked in the rehab unit and then moved into the trauma unit. I worked on every floor, so I was in there with the AIDS patients and the cancer patients, and I was in the neonatal ICU. I have a very unique physical therapy presence. I worked in more fields than most people in physical therapy. You go to school and you're like, I really want to work with people who do sports. And so they end up being orthopedic, and then sometimes you end up doing neurology because you did something in a neurological clinical and you got really interested in that. I loved it all, and I worked in inpatients, I worked in outpatients, and I am as passionate about my job today as I was when I first walked into that rehab unit back in 1989. I worked in the hospital here for many years, and I opened my own private practice at the end of 2022. And my pelvic floor educational journey began right about there, but it was also the time when my own pelvic floor awareness of what pelvic floor therapy was, that all started to play around at the same time. So I fell off a horse when I was 12 and broke my tailbone. And all tailbone injuries are pelvic floor injuries, but we didn't know what pelvic floor was in 1978. So bad injury with that. Took about 2 years before the pain from that finally started to go away, and then a boy who had a crush on me pulled a chair out from underneath me because he thought that would be really funny. And we started the process all over again. So the first injury was when I was 12, and I started leaking when I was 12. I was sexually assaulted when I was 15, and women who are sexually assaulted are at a really high risk for pelvic floor dysfunction. Again, back in 1981, we didn't really know what pelvic floor therapy was, so nobody said, hey, you have a pelvic floor injury, let's go take care of that. So I gave birth to my first son when I was 30 and had a very serious tear. So we all hear about tears. My tear went all the way to my rectum because he came out really fast. And so they sew you up and they're like, here's your 7-pound baby, go live a nice life, and nobody does anything about that. Okay, but if you tear your shoulder, you get a little tiny bicep tear, you're going to PT. Nobody sends somebody with a 4th degree tear to PT. And we're going to get into why that is ridiculous. I have had probably every pelvic floor surgery that you can have minus one. And each time I had one, I said, why is this happening to me? What's going on? And it was just, you have bad luck. You have bad luck. So I had all this surgery, and then after all my surgeries, all my problems started to come back again. So that's when my journey began, because we can get into details about the surgery. You may not want to, but there's only so many that you can have, and so if they were failing, I needed to find other answers. And so I went to what's called the Herman and Wallace Institute. There's only about 2 places in the United States where you can get pelvic floor education, and Herman and Wallace is the big one. And so the way it works is they live in Maryland, I think, and they do these satellite courses. So you travel, but not to Maryland, and they do a Zoom class, and you're in a room with a whole bunch of people, and there's a bunch of TAs in there to sort of direct your hands-on stuff. And yes, in a room of about 15 to 25 people, you're all learning on each other. So it's a very intimate thing, and it's not really, a lot of PTs are like, no, we're not doing that. So we've all been patients because we can't learn how to do this without becoming patients. So I'm passionate about this population because I understand where they're coming from, because I've probably had even more problems than they have. So when we talk about pelvic health, we tend to get very uncomfortable about that. The symptoms associated with pelvic floor dysfunction can be embarrassing, and we don't feel quite comfortable asking questions or sharing with our friends. So when I began to have my surgery, they knew at work that I was going to be out for surgery, and they were like, "What are you going to have done?" Do you really want to know? Because I was embarrassed. I was embarrassed about what I was going to have done. But at the same time, I thought, why should I be embarrassed by this? And so when people ask, I would be like, no, all my parts are falling out, so I'm going to have them put back in. And I was shocked by how many women said, oh, I had that surgery. And then they said, oh, I've had that surgery twice. And so these problems are actually more prevalent than I think most of us know, because I'm 58 years old, and when I grew up, we didn't talk about these parts. When I was sexually assaulted and my parents wanted to know what was wrong with my attitude, and I told them I was sexually assaulted, they said, oh. And then they went their way and I went my way. So we're going to talk about some things that might make you uncomfortable today. Here are the things that are symptoms of pelvic floor dysfunction. These are most of them, but it's not inclusive. Urinary incontinence, pelvic pain, hip or back pain, constipation, fecal incontinence, painful intercourse, difficulty urinating, painful periods, organ prolapse, and any status post-abdominal or pelvic floor, or possibly, depending on the structure of the hip surgery. So any kind of surgery. Okay, so we're going to take you out of your comfort zone, because all the things that I described, mostly with the exception of pelvic organ prolapse, although hernias are a form of that, painful periods are about the only other thing on that list that men don't also suffer from. So when I began this journey, I could barely say the names of the body parts in a room by myself. And so when I began this journey, I was like, I have to be able to say vulva in front of someone. We're going to say a lot of words today, and we do not need to be ashamed of our body parts. We do not need to feel embarrassed of our body parts. When I went in for surgery, they run you through the surgery, and the first person comes in and says, "What are you here for today?" And you have to say. And then the next person comes on, and they're going to stick an IV in you, and they say, "What are you here for today?" And you have to say. And by the time about the fourth person asked me that question, I was still so embarrassed about what was happening to me that my response was, "Can we please just say that I know what surgery I'm having today?" We should not feel that way about our bodies. When things start to fall out and they're not where they belong, that is nothing to be embarrassed about, because you're going to find out that about 70% of women over the age of 65 have something falling out. Okay, so why am I out there trying to get everyone I know to talk about pelvic health? Because I'm a physical therapist, and the vast majority of pelvic floor therapists are physical therapists. There's a few occupational therapists. I am a female physical therapist, and like 99.9% of the physical therapists that are pelvic floor therapists are women. And I had no idea what pelvic floor therapy was. I had no idea what we did. And if I didn't know, then your primary care provider doesn't know. And so if I can get out to the community and I can educate the community, you can ask your primary care provider, "Hey, can you get me, I think I could benefit from pelvic floor therapy." And we have to learn to advocate for ourselves. Your primary care providers are working so hard. They are running patients through, not because they necessarily want to run you through as quickly as they can, but that's the way the system is set up. They're getting you in there, they're spending like 5 or 10 minutes with you, and they're seeing the next patient, and they're trying to chart, and then when a pelvic floor therapist calls them up and says, hey, can we get together so we can talk about maybe how I can help your patients? They don't have time. So it's not their fault. We just need to get out and we need to educate the people about how it can be helped. So it's a highly specialized area of physical therapy. Most people in physical therapy don't know what pelvic floor therapy does, and there's a huge need for it. Like I said, 70% of women over the age of 65 have something falling out. Okay, so what is the pelvic floor? The pelvic floor is actually 3 layers of muscles and 5 layers of fascia. So if you don't know what fascia is, when you're cooking a steak and there's that, it's not a very good quality one, and there's that really thick stuff in there sort of between the layers of meat, that's fascia. And that can be very thin or it can be very thick. The fascia that's in your pelvic floor is actually quite thick. The pelvic floor acts as a hammock for our internal organs. So the pelvis sits right in the middle of our body, and it drives every movement that we make. So if I don't have good stability through my pelvis and I'm trying to do things with my feet out here, I'm going to end up with hip injuries or back injuries. If my hips or backs, or my hips or back is weak, the muscles of my pelvic floor might try and do some of the work that those muscles aren't doing. And so that will result in dysfunction. You can have pelvic floor muscles that are weak, and so when you're trying not to pee during exercise, they might not be strong enough to actually hold the urine in when you're exercising. It can also be that they're tight. So with me, as a 12-year-old breaking my tailbone, and then again as a 14-year-old breaking my tailbone, and then being sexually assaulted, I kept my tension in my pelvic floor. So we all know people who say, oh, I keep my tension in my neck, or I keep my tension in my back. Lots of people keep their tension in their pelvic floor. And so we call that an upregulated pelvic floor. So the pelvic floor is tight. And then if you have a tight muscle, it's easy for you to see that if I casted my bicep, and then I was trying to move my bicep, and I couldn't, but I wanted to strengthen it, and this was the only place I could move it, that I wouldn't really make my bicep very strong. I need to be able to open my arm all the way up and bend it all the way through so that I can strengthen that muscle all the way through the range of motion. The same is true for your pelvic floor. So if your pelvic floor is upregulated and very tight, you don't have the range of motion to strengthen the pelvic floor, to support your internal organs, or to stop you from peeing when you don't want to. It can also lead to constipation. Okay, so who can benefit from pelvic floor? Women who are pregnant and postpartum. Anybody ever hear of anyone going to pelvic floor therapy before they push a big 7 or 8 or 9 pound baby out of them? No, they don't go, although it is becoming more common now. We can teach you different positions that you can get into in different parts of your labor. The pelvis is sort of shaped like a funnel, and so we want the top of the pelvis open early in labor, but by the time we get to the end of labor, we want to sort of transition and have that bottom part of the pelvis open so we get those head and shoulders out, and we can teach you those different strategies to help you through that. We teach you how to stretch so that you don't tear. We give you exercises. Women who are pregnant will get what's called a diastasis recti, so they'll get a separation of their muscles in the front part of their abdomen, which then later on impacts their ability to have good core control, and they end up with a lot of back or hip pain after that. So we give you exercises to prevent the diastasis. If we don't prevent the diastasis, we work with you afterwards to heal that. We do realization of C-section scars. A lot of women get pregnancy pain. I used to, when I was working at the hospital, we get lots of people in there for pregnancy pain, and a lot of times we go, yeah, you're just gonna have to have a baby. And now I know that there's a whole lot more than that. So if you have a friend who's pregnant and they send them to a regular PT for their pain, tell them to go see a pelvic floor therapist. They're gonna get more help. Urinary incontinence. We have stress incontinence or urgent incontinence. Stress incontinence happens when we cough or we laugh or we're exercising. And urgent incontinence is when we're sitting there and everything's fine, and then we stand up to go do something and suddenly we have to go to the bathroom. And we have to hurry and we have to go right now, and if we don't go right now, we're gonna pee our pants. Half the time on the way to to the toilet, we're thinking about peeing, and so we're leaking all the way to the toilet.
Mhm.
Urgent incontinence can be pretty common in men who have had prostate problems or post-prostatectomy. Men don't typically get stress incontinence because they have a little bit different system. Sometimes if you have difficulty emptying your bladder, or if you like pee and then you stand up and you get a little dribble afterwards, that's all sort of a form of incontinence. If you have fecal incontinence or constipation, pelvic floor therapy can help you. Back pain, hip pain, and sciatica. If you have been treated for hip pain, back pain, and sciatica, and you got a little bit better, but you didn't get all the way better, there's a really good chance that your pelvic floor is driving those symptoms. All of those nerves come out around L5S1 and they're running right through the butt. Some of them are running right through the pelvic floor. And so as those muscles get tight or dysfunctional, you'll get nerve entrapment and pain. Women who have painful periods or recurrent UTIs, a lot of times we're being diagnosed with UTIs that aren't really UTIs. And a lot of times they're just putting you on antibiotics because they don't know what else to do. It could be that your pelvic floor is driving you problems. Pelvic organ prolapse. So if you had a hysterectomy, your uterus is held up with suspensory ligaments, and so when you take the uterus out, you lose those ligaments that hold things up. Even if you don't have a hysterectomy, your uterus can still fall out. So either way, you're not immune to pelvic organ prolapse. Your bladder can collapse into your vagina. Your rectum can collapse into your vagina. Your uterus can fall into the vagina. And if you don't have a uterus, the cervix and the small intestine can fall into your vagina. We grade those on a 1 to 4 grade. And so 1 is pretty minimal, but 4 is hanging outside your body. If you're a 4, you're going to have surgery because I'm not really going to help you with a 4. But we have clinical evidence that shows that we can reduce the grade of your prolapse by a whole grade. And we also have a lot of clinical support that most pelvic floor physical therapists will tell you that they can make your prolapse improve by up to 2 grades, depending. Like if you're a 3, sometimes they get you down to a 1. If you're a 2, they're probably not going to get you to a 0. But 1 is so common that I think if we took the general population after having children, I think you would find more people had a grade 1 than 0. And it's so common that we actually consider grade 1 normal. And most people with a grade 1 are not going to have any symptoms. Painful intercourse, this is for men or women. We can treat that. And no, pelvic floor therapy is not just for women. So we've heard of chronic prostatitis. Sometimes they call that BPH. There is BPH, but this chronic prostatitis is sometimes called BPH, and it is not. So chronic prostatitis is you're a guy and you get up in the middle of the night, you go to the bathroom, and you can't empty your bladder. And so you kind of have to hang out for a little while, and then you go back, and then you try it again, and then you hang out for a little while, and you go back, and finally after 2 or 3 or 4 times, you've got your bladder empty. So if that was BPH, if your prostate was so big and it was so in the way that you couldn't go to the bathroom, why can you go to the bathroom in 10 minutes, and then why can you go to the bathroom in 10 minutes? Most likely and most often, it is a upregulated pelvic floor. And so as we're getting older and we're losing some of our abdominal integrity and we're maybe changing where our center of gravity is because we're not exercising as much, but we're drinking a lot of beer, that will change the tension in your pelvic floor, and that can result in that nighttime pee. Post-prostatectomy. So if you have prostate cancer and you end up having to have a prostatectomy, it's very common to be incontinent after that. And the clinical research shows that we can decrease your post-prostatectomy incontinence by as early as 3 months. So if you're going to be incontinent for 6 months, we'll have it fixed in 3 months. If you are incontinent before your prostatectomy, we are probably not going to help you with that. We might decrease it so that, you know, maybe you're wearing some kind of a pad instead of a full-blown diaper. But if you were continent before, there's a good chance we're going to get incontinent after. Hernias is another example of, it's kind of like a pelvic organ prolapse. You have this cord that actually comes out of your belly and descends down into your groin and into your testicles. That is a hole in a canister, okay? So my core is a canister and my pelvic floor has holes in it. It's got the vagina, it's got the rectum, it's got the urethra. And it's the same for men. They have to have a hole in the back and a hole in the front. But they have this extra little hole right here where the spermatocord comes out, and that is, if you don't have good pressure management, you don't have good pelvic floor strength, that's where you're going to blow out. And that's very common for men to blow out. So pelvic floor therapy can help you with your hernia. So what does pelvic floor therapy look like? Okay, so when you go to a pelvic floor therapist, everyone's like, oh, she's going to have her fingers inside of me. And yeah, probably we are. But it's way more than that. So the first thing we're going to do is we're going to look at your posture. We're going to look at how you offload and your core stability. So we're going to kind of look at how you move. We're going to have you do one-legged squats, two-legged squats. We're going to have you lay down, lift up leg. And what we're going to be looking at is what your pelvis does and what your hips do when you're doing those movements, because that's an indication of what your pelvic floor might be doing. We're going to do an external exam. We're going to touch muscles. We're going to touch parts. We're going to push and we're going to pull, and none of it hurts, okay? And then we're going to do an internal examination. Okay, so if you go to pelvic floor therapy and you're like, I don't want to do a pelvic floor, I don't want to do a muscle exam, I don't want you to do an internal exam. We are not going to do an internal exam. This is 100% about you, it is not about us, and we meet you where you are. Now, having said that, if you came and saw me for your knee, and I never put my hands on your knee, you would kind of be like, how does she know what's going on? Okay, it's kind of true for the pelvic floor. So if you don't want a pelvic floor exam, we're not going to do the pelvic floor exam. And we are still going to try and help you. We hope that eventually you will trust us enough that you feel comfortable doing a pelvic floor exam. Because what we are looking for is we're looking for the range of motion of your pelvic floor, we're looking for the strength of your pelvic floor, and we're looking to see if you have tender spots in your pelvic floor. If you have shoulder pain because you carry your tension in your shoulder, you know, you get that little spot that always hurts, it's the same in your pelvic floor. And so if we're not getting in there and finding those pelvic floor trigger points and dealing with those trigger points, we might not be able to deal with your dysfunction as effectively and as quickly. Okay, so what does treatment look like? So treatments usually require ongoing reassessments. So depending on what we find on your pelvic floor exam, there may be internal work every single time you come in, or there might be internal work, you know, maybe every 3 or 4 times. But if I am not continuing to do an internal exam, I can't really measure what your progress is. I can't really see if what I'm doing is actually helping you. So there's a lot of manual therapy. Manual therapy is manually stretching you, it's addressing trigger points. We do different types of massage that fall under manual therapy. We might be mobilizing the joints. We're going to do a lot of therapeutic exercises. There is a lot of exercises that go into pelvic floor therapy. There's also biofeedback. I don't personally use biofeedback. And if you go to a pelvic floor therapist and they put you on biofeedback and they put you in a room and they walk away and then they come back in an hour, take you off your pelvic and your biofeedback, and then you go back the next time they do that, and that's what your pelvic floor therapy looks like, you need to go somewhere else. There is pelvic floor therapists that are not trained to do internal work, and you'll come to them and you'll say that you're peeing, and they'll say, okay, well you're weak and we're going to put you on biofeedback and make you stronger. Kegels could actually make you worse, and so you don't want to go see a pelvic floor therapist that can't do internal work. Because if you have that upregulated pelvic floor and you have this really tight pelvic floor and then you start doing Kegels there, all you're going to do is give yourself a whole bunch of trigger points. You're never going to get the range of motion in the pelvic floor to get the strength. And so, you know, 100 Kegels at the stoplight, which is what I was told, is not going to solve your problem. We also use ultrasound imaging. So you might come to see us and we might ask you to have a full bladder when you show up, and then we're going to tell you to go to the bathroom, and then you're going to come back in and we're going to do ultrasound of the bladder to see if you have pee in it. We can also use that to see what muscles are contracting. And so I would prefer ultrasound imaging over biofeedback because it actually will tell us. Sometimes we want you to use your transverse abdominis, but what you're actually activating is one of your obliques. And we can put the ultrasound imaging on you and actually show you, okay, right now you're contracting your oblique. Right now you're contracting, okay, now you have your transverse abdominis. So it's really good, helpful feedback. I currently don't have ultrasound imaging because it's not cheap, but one day I will. Why is it important to know what we do and what we treat? Because you have to advocate for yourself. Like I said earlier, your primary care provider does not know what we do. My OBGYN has done 4 pelvic floor surgeries on me and never once said, you can try pelvic floor therapy. She never, and when I asked her, why is this happening? My answer was bad luck. That was not what was happening. I did not have range of motion in my pelvic floor to have enough strength to stop myself from peeing. I did not have enough strength in my pelvic floor because I didn't have enough range of motion to actually hold my organs up. And so and I didn't have good pressure management. So if I'm picking up heavy things and I'm holding my breath, I don't have good pressure management. Even if I'm not holding my breath, but I'm bearing down everywhere, I don't have good pressure management. That's going to make stuff fall out. And she should have said that. She didn't say that because she didn't know. And so the point is, they don't all know. So if you know, you can ask for help. If you go to a pelvic floor therapist, if you go to your OBGYN and you're asking these questions and you say you want pelvic floor therapy, I would be shocked if they said no. I would be shocked. If they say no, that is not your OBGYN. Okay, so let's talk a little bit about posture, because posture will do more for you and your pelvic floor than probably anything I can do for you. So I want you to look, okay, so we all look at this and we think, okay, this is bad posture and that's good posture. Okay, that is bad posture, but so is the good posture. So our pelvis sits at the bottom of our core. It's pretty much the center of our center of gravity. Okay, that's what's holding everything above us, and it's holding this still enough so that our legs can do the things that they need to do. So our pelvis should be pointed at the floor so that it can work and hold my organs without having to work to hold things in there. So what most people do is they lock their knees and then they throw their hips forward. So I'm really exaggerating this, but that's kind of what she's doing over here. When we do that, we tighten our deep rotators in our butt, and we are hanging on all of our ligaments, and we're not doing work. So now we're going to get tight, deep rotators in our butt. It's going to give us some sciatica and hip pain. And now what's happened is I've taken my pelvis, which is pointed at the floor right now, and then I pointed it here. So her pelvis is pointed that way, but it should actually be pointed at her ribs. So to find that, you put the heel of your hand on your hip bones, and you put your fingertips on your pubic bone.
Can we all do that together right now?
Absolutely.
We should stand up anyway. It's been a minute.
When you do that, now I have a little bit of a pooch, but I can still find my hip bones and I can still find my pubic bone. And I want my hands to be perfectly perpendicular to the floor. Now, when you first start doing this, you're going to squeeze your butt, you're going to squeeze your stomach, and you're going to be like, where is that? So it should be kind of relaxed. You just kind of want to move your pelvis without squeezing your butt cheek and find where your hands are perpendicular to the floor. And when you do that, then you kind of want to pay attention to what are the muscles in your butt doing, because they should actually be relaxed. And then what you want to do, holding that position, is you want to look at what your ribs are doing. So her ribs, if you look at her ribs, they're actually pointed this way. Her pelvis is pointed over here, and her ribs are pointed over there. What we want you to do is you want to find pelvis neutral and be fairly relaxed. And then you want to point your ribs at your pelvis. So a lot of people tell us, stand up straight, put your shoulders back, stick your chest out. Okay, kind of, but now my ribs are like this. But what I should be doing is pointing my ribs at my pelvis should be perpendicular to the floor, my shoulders should be back, and my head should be tall. This is good posture, this is not, okay? The ribs pointed at the pelvis puts my center of gravity in the center of my abdomen, which means that I don't have to work hard to stay standing. So I saved posture for the end because if you watched me the whole time I talked, I was doing this. It's really hard, and we have a lifetime of habits to overcome. And I've actually been working at this, and I still find myself doing this. So it's awareness, and you always want to sort of check that. The other thing that you want to do is you want to check that before you go to do something difficult. If they tell you, I want you to stick your chest out, and then I want you to bend down and pick this up, you're not in good posture, you don't have good core control, you're going to have poor breath management, and you're going to have increased pressure on your pelvic floor. So if you point your ribs at your pelvis, and your pelvis is perpendicular to the floor, and then you go to do something difficult, you're going to tighten your abdomen. But it's easy to tighten your abdomen, it's easy to pull your lower abdominals in with your upper abdominals, because this is how your core has decided it needs to function. It doesn't function like this, and it doesn't function like this. And so your posture is the first thing that you can do to try and improve your pelvic floor dysfunction. So I'm going to show you why she doesn't have good posture on the other side. Because if you look at where her pelvis is pointed, her pelvis is forward. She's not perpendicular to the floor. If she put her hip bones and her hands on her pubic bone, her hip bones are going to be forward of her pubic bone. And then her ribs are pointed out in front of her pelvis. So she's still, even though we think that's good posture, it's not good posture. Most pelvic floor therapists are going to go all over that with you, but I guarantee you that most of your physical therapists are going to say, yeah, that's okay. I would have said that was okay. Okay. So I managed to get through that in 35 minutes. Which gives you plenty of time to ask questions.
So I was seeing a physical therapist for a year or two, and I had I was having a lot of problems with my back, and adaptively tightened hip flexors, anteriorly rotated pelvis. I think I worked a lot on that. I think it's like you can loosen those tight hip flexors or those shortened, but it takes like 10,000 reps. But 5 times a day. So I'm just wondering about. Can that be?
Yes.
Completely.
Your pelvic floor therapist is going to approach that differently than your regular pelvic floor therapist. We look, and you probably already found it with your doctors and your nurses and your physical therapists. Every person has a different journey to become what they are. I am a very different physical therapist than all the other physical therapists I know that are not pelvic floor therapists. Pelvic floor therapists tend to kind of be in agreement about stuff, but we have different ways of doing things too. But by and large, we look at your whole body. So if you're having back problems, your back is going to be affected by your hips. That's probably fairly obvious. Okay, but your hips are affected by your feet, because if you have flat feet, where you put your foot is going to affect where your hip is, right? Because your knees don't move this way or that way. So if you have flat feet, where you put your foot is going to affect where your hip is. There's also lots of modalities that they use in regular physical therapy. They're going to go put you on Easton, and they're going to put you on ultrasound, they're going to do different things to sort of passively treat you for that pain. We use very little of that. We do lots of manual therapy. There's lots of releases. There's lots of, a lot of times that we're not tight because we're tight because we're weak, and what we need to do is we need to strengthen in a lengthening position. So your muscle cells actually look like this, and they sit around, and then when you contract them, they do this, and then when you're done contracting, they do this. So my bicep shortens when I do this, but when I do this, I am actually using my bicep, not my tricep. My bicep is lowering my arm instead of my tricep doing it because I'm fighting gravity here. So what that looks like is this, and it's a contraction. So we use lots of lengthening contractions in physical therapy, in pelvic floor therapy, which I personally find to be much more effective than giving you just a passive stretch, although we do that too. But we're gonna look at your feet, we're gonna look at your knees, we're gonna look at your neck, we're gonna look at your shoulders. It's a totally different picture.
Thank you. Is Dr. Brooks in Medford aware of you? She's a Eurogyne.
I sent all the Eurogynes and what are the other ones called? Urologists, even the proctologists. They have my handouts. It is really needed in Siskiyou County, and I'm the only one in Siskiyou County who can do it. But where I work, I can't take Medicare, so I can't see Medicare patients. So all of the Medicare patients still have to go up to Medford for that. But
Is there a reason for that?
so
Other than the state?
no, the reason is, so I have a journey that brought me to where I am that most people aren't really interested in, so I'm not going to share. I want to practice physical therapy the way that I want to practice it. I don't want insurance companies telling me what to do, and insurance companies dictate care. With pelvic floor therapy, it is kind of iffy how much your insurance will cover. Every insurance is a little bit different. So I really struggled in my old job, and so I like where I am. I can't take insurance. So the problem with Medicare is the way that the Social Security Act was written. Physical therapists are considered a service, so it's like a lab or an x-ray. So I am not allowed to what's called opt out of Medicare. So if you're a doctor or a nurse, you can opt out. You can say, I don't want to play the Medicare game, and the Medicare patients can come and see you and write you a check for whatever you're charging for your service. Physical therapists cannot do that. So I either take Medicare and bill Medicare, or I don't participate in Medicare, which means I cannot legally treat any Medicare patients. I recently started the process to see if I could go ahead and do Medicare, and it became very invasive, and it gave me a really bad vibe, and so I backed out. I didn't do it. But Medford has a pelvic floor therapy clinic, and that is where I received a great deal of my training. When I did my training, there were 2 classes that I was able to take in Medford, and those people were my TAs. So there's an option, it just means you have to drive. And they do it a little bit different because they want to get paid, right? Yeah.
So you can't take Medicare patients, even if they
Want to pay
are
more.
private pay?
Right.
Okay.
All the other people where I work can do that, I just can't do that.
So that-
Speech therapists and PTs, I think occupational therapists also, and then any labs and any x-rays. Medicare patients cannot pay cash for that. So you can't go somewhere that doesn't take Medicare. Yeah. Yeah,
And where do you work? Are you at the
I'm currently at the Well.
Okay.
Yeah.
Do you do other kinds of physical therapy? or-
I do all kinds of, I do all.
Okay, and can you take other insurances, but just not Medicare?
So what we do is we give you a super bill. So we all sort of had a similar journey that brought us to the Well. And we very much want healthcare to be about health, okay? And when you are a provider and you contract with an insurance, you have to do you agree to do what the insurance says, and you're going to do what the insurance pays for. And I will give you a super bill. So what will happen is you'll come see me, you'll pay me, I'll give you a super bill. And you can submit that to your insurance. And if you have out-of-network benefits, they should cover that for whatever that is. Now, having said that, depending on what your insurance covers for pelvic floor therapy, that may be different. Like if you come see me for incontinence, 50% of your insurances are not going to pay whether or not you pee your pants because they don't really care. If you come to me for sexual dysfunction, really good chance that's not going to be paid. But if you come to me with sexual dysfunction, peeing your pants, and back pain, you see where I'm going. I want to be able to treat people for what they have, so I charge a different rate, and I love what I do.
What if it's just or just paid?
And I can see you for that, and that's more, if you have out-of-network benefits, it's probably gonna be covered. Yeah. It really depends. What I'm seeing, I've been doing this since the end of 2022, and what I'm seeing is some people submit their super bill and there's a check. Other people are submitting it, and then they have to submit all this other stuff, and then they have to call people, and they have to talk to people, and they have to jump through a whole bunch of hoops. But it's starting to sound like once you jump through those hoops with a particular provider, that that hoop is there, and it should work more smoothly after that. Okay, and I personally, I don't charge much more or less than what their contract rate is, and so I would actually be surprised if my patients weren't getting it covered. So far, everybody has, but that doesn't, you know, I don't make guarantees, and that's why I don't take insurance. And it's kind of, you know, a lot of pelvic floor therapists are out-of-network providers, and it's for that reason. So they'll give you a super bill. If your insurance provider doesn't ask you for documentation, they just want to see the bill, probably cover. But if they start saying, I want to see the documentation, because what will happen is you'll come to me and you'll say, I have back pain, and then a good example is a patient came to me and I was seeing her for this other thing, and then she got attacked by a kayak and had all this neck injury, and so she came to me and I was like, okay, well, let's work on your neck today. And I can do that, but you can't do that when you work for an insurance company, because they're not going to pay you for the neck, they're only going to pay you for what you started with. Yeah.
Do you have a couple of exercises that you recommend to start getting your pelvic area healthy?
So that is a really hard question for somebody that's standing at the front of a counter, and I'll tell you why. My pelvic floor dysfunction had to do with an upregulated pelvic floor. So when my OBGYN told me, go home and do Kegels, I did Kegels till the cows come home, and it actually got worse. Because what I needed to do was lengthen my pelvic floor. Some women have a really long pelvic floor because they're big abdominal breathers, and they have poor pressure management, and so they might have more of a dropped down pelvic floor. And so what they need to do is a whole lot of Kegels and a whole lot of other things. We gotta work on the hips and all this other stuff. So I'm very cautious to say, go do these things, because they might not be right for you. Posture is huge. Really being aware of your posture is big. And then also when we breathe, we should breathe so that our ribs expand. And women who've had babies, we do this when we're pregnant because we're trying so hard to make room for that baby and our lungs and all our guts. And what happens is we shorten in our back here. All these muscles get tight. The intercostals, the muscles between our ribs get tight. And then no one sends us to someone who knows what they're doing so that we can learn how to breathe in our back again. And so we stay tight back here. and we tend to be more of an abdominal breather. And so when we're abdominal breathing, we're putting a lot of downward pressure on our pelvic floor. So working at trying to, you know, in my clinic, we do a lot of working on trying to learn how to breathe into your back ribs and stretching those. And, you know, so you kind of want to take a big breath in, and you kind of want to have your hands on those ribs and pay attention to what the ribs are doing. And then you want to sort of learn to breathe that way. You want to sort of learn to, you know, when I was in high school, they were like, oh, don't breathe up here, breathe down here. Okay, that was like the worst thing we could have been taught. We need to breathe like a soda can, you know what I mean? It all works together. And that diaphragm, as that diaphragm is coming down, the pelvic floor has to descend, right? Because if my diaphragm's coming down, then I don't have much room for my guts, so my pelvic floor is going to come down a little bit to make room for my guts, which is going to kind of stretch my pelvic floor and make room for it. But a lot of us, the posterior aspect of our diaphragm is not moving very much because we lost that when we had kids. And so we learn how to move those ribs, we learn how to move that posterior diaphragm, then we move a little bit more into the posterior aspect of our pelvic floor. So other than that, it's pretty hard for me to tell you, but you would do more for yourself probably just paying attention to your posture and breathing certainly than if you did nothing.
How important is it to do Kegel exercises?
So it really depends. And most of what we do is very little Kegel, okay? So if you are doing Kegels, but you have a tight pelvic floor, you're gonna hurt yourself doing Kegels. If you have a drop-down pelvic floor, doing Kegels will probably help you. But the Kegel alone is not sufficient to really give you. When we're jumping, so some women, they'll run and they'll leak when they run. But they can walk really fast and they don't leak when they walk really fast. So we have to learn to sort of load the tissues. And so when we're doing Kegels, that's helpful. But if we're not also doing a lot of stuff with our hips, we're not learning to load those tissues and load that pelvic floor for different functions in order to manage our leaking. And it's the same for prolapse. So if you have a prolapse and I'm helping you with a prolapse, we're going to do some Kegels and we're going to do some different things for your prolapse to try and get you to hold your prolapse up. But then a lot of what we're doing is laying down, right? Because it's pretty hard for me to, I mean, I do it, but it doesn't work very well for me to have my fingers inside of you while you're doing an exercise. And we do it, so it's, you know, pelvic floor therapy is not glamorous for either one of us. But it's helpful. So what we're going to do is we're going to teach you some Kegels, but then we're going to teach you other strengthening things. And then we might teach you to sort of, okay, remember what it felt like when you did the Kegel, when you did it this way, and now we're going to load this tissue and we're going to do that. And we're going to see whether or not you hold that pelvic floor up where it needs to be able to support the organs when you're doing the activities.
I think a lot of women have an idea of what a Kegel exercise is, and I thought I knew how to do them. And I found out I didn't know how to do them.
And so that's very common too. And we actually, that's one of the reasons we want to do internal work with you, is because sometimes you'll be like, okay, do a Kegel, and they'll be like, okay, and you literally didn't feel a thing. And that's a really hard thing to learn. A lot of times we'll tell women, you know, when you're peeing, try and stop your pee. We hate telling you that because that can lead to bladder infections too, but it's still a way for you to kind of learn how to do a Kegel. You're either trying to stop passing gas, or you're trying to stop urine, and that'll kind of give you a Kegel. But again, Kegels are not, there's a lot of pelvic floor therapists that like teach you how to do a Kegel, and they're like, go do 10 a day, and then that's it. Because we're finding that the Kegel is not all that the Kegel's cracked up to be.
I thought it was just contracting the muscles that you are aware of when you have climax, but it's a lot more than that, and it's more about lifting up.
Yes. We want you to lift. So a lot of times we'll tell people when you cough, you know, once we get you to find your pelvic floor and contract your pelvic floor and figure out what you're doing, when you cough, we'll tell you, we want you to kind of lift and push that cough out with your pelvic floor. But again, muscles in our body that are slow twitch and fast twitch. So our big muscles tend to be fast twitch muscles. So my glutes and my quads are fast twitch muscles, which mean they want to take a big load and they want to work really hard for a short period of time. So there's my sprinting muscles, right? My transverse abdominis is a little tiny postural muscle. It's not very strong, but it has to work all day. So I'm going to tighten that muscle and I'm going to hold that tight or do whatever. That's a slow twitch. It has some fast twitch, but primarily it's a slow twitch muscle. The pelvic floor is actually one of the few muscles that has almost an equal amount of slow twitch and fast twitch. So when we're training the pelvic floor, that's also something we're doing. We're working on whether or not you can hold that contraction at a good strength for how long, and we're also looking at how often and how quickly you can achieve a full contraction, relax, and achieve a full contraction. So we want you to be able to do 10 fast contractions at full strength, and in all the women that I've seen, one could do that. But they weren't all symptomatic either. So they weren't leaking or whatever. So I do that a lot with imaging. I'll tell people, your imaging might say that you have, a lot of degenerative disc disease and facet disease and all these things. But honestly, if I pulled 100,000 people off of the street and I did imaging on them, I would not be able to look at the imaging and tell you which ones had symptoms and which ones didn't, because it wouldn't show that. And so it's kind of the same with pelvic floor stuff. I mean, I have lots of women that have a prolapse, and we work on the prolapse so it doesn't get worse, but they have no symptoms from the prolapse. And then there's other people with like a grade 2 or 3, which is a pretty significant prolapse, and like they literally had no idea. They didn't feel the sensation of having it, and then there's other people that are stage 1 and they have trouble peeing. So yeah, it just depends. But get the help you deserve. We all should have that help. I think everybody. I think all women should have pelvic floor therapy at least once, just to get an assessment. And I think men, if they're symptomatic, should go. They never do. I mean, I've had a few men, and they're always like, "You want to do what?" Because you only have one hole for us to access your pelvic floor. But even still, even if you didn't want that, and you were up multiple times at night at peeing, and you told the pelvic floor therapist, "You're not doing that, but I really want some help," they would help you. It is not normal to leak. It is not normal to get up 4 times a night and pee. It is not normal for your pelvic organs to prolapse. Now, do they? Yeah. But just because it happens, and it happens often, doesn't make it normal. And I will tell you, I leaked from the time I was 12 until I started to do this, and I do not leak anymore. So it's fixable. And I'm also not having things fall out anymore either.
Lauralee, do you mind telling us the name of the place in Medford? The name of
It's
the
at Asante.
Asante.
Yeah,
Okay.
it's at Asante.
Okay.
And they have, I think they have 3 or 4 pelvic floor therapists. So, I mean, you have to wait to get in, and they do it different, but they're brilliant. They know what they're doing. They're very smart.
There is a tool called Oliva, and Dr. Brooks had me do that because she didn't want me to have to travel up to Medford all the time for therapy. And you put it in the vagina, and it senses your contraction, gives you feedback
Right.
on whether you're doing it correctly or not.
Right.
And so I did that for a while, and it taught me how to do the Kegel exercise correctly.
And you can even get those on Amazon.
But it is expensive. I think it was $500.
Oh, no, you can get them on Amazon for like, it's either $150 or $200 now. And they work. They work. I'm just not a fan of, it's just not about the Kegel. I mean, the Kegel plays a role, but most of us, I don't want to say we don't care about the Kegel, but the Kegel is a small piece of a bigger picture. And this was a lot of school and it was a lot of work. And your OBGYNs care about abnormal tissue, they care about surgery, and your pelvic floor therapy, we care about something else. And so you get a different view, and I don't think it ever hurts to have more than one opinion.
Are there any more questions?
I have a question. I'm a little confused about Medicare. So once we achieve a certain age, we go on Medicare, right? But I don't know, can we not come to you?
Right. A physical therapist, occupational therapist, speech therapist, x-ray, and lab. You cannot pay cash for that if you are enrolled in Part B Medicare.
Really?
Yeah. Those are the only ones. You can go see a nurse practitioner, you can go see a doctor, you can see a dentist. You can do any of those things and pay cash for it, but you can't
Well,
pay.
why don't you do something about it?
Because it's part of the Social Security Act. So I will tell you right now that there are people trying to do something about it, but we have to rewrite the Social Security Act. And not in my lifetime. I would like it to be in my lifetime, but it won't
It
be.
would seem like you could go in and just say, well,
Well,
I'm not on
it's the
Medicare.
Medicare thing. They will pay for glasses or hearing aids. So
You really, when you want to start badmouthing insurance, this is the girl to talk to.
You don't hear very many people opt into subpart F. Some of my other aging folks they said, man, don't even go with B or even get into subpart F. Does it still encompass the same?
I don't know about that one. Now, if you don't enroll in Part B, so I do have a Medicare patient who is Part A, but she did not enroll in Part B, so I can see her. But not very many people don't enroll in Part. My husband just turned 65 and he enrolled in Part B. I'm like, what? You just watch your physical therapist.
Did he have the knowledge or did
No.
someone point him down the road of part F?
No, so
Okay.
I'll be looking into that because I got another 2 years.
Okay, so you're saying A and B. A is Medicare.
A is like, you don't have to pay for A.
Right,
Yeah.
right, okay. So if
That's
you
not
have
school.
A and not, okay.
Yeah.
If a person has A, they can come see you.
If they do not have B.
If they do not have B, unless my B,
If you are enrolled in Medicare B,
Right.
you cannot see,
period.
no, not, oh, okay, no, I have a supplemental, which is my secondary insurance. Okay. So I can come see you, and it's a big possibility that my secondary insurance would pay.
your secondary insurance will pay for, okay, so I don't know your, okay?
Right.
The way it usually works is a supplemental Medicare policy pays for the portion that Medicare covered but didn't pay. Okay, so that's a really important distinction
Right.
because Medicare pays 80%, right?
88, so my supplemental pays the 20.
Right, but your supplement will not pick up what was not covered,
Right.
okay? So if Medicare didn't cover you because you were seeing me for incontinence, your supplemental's not gonna pick that up, okay? I mean, there are very few exceptions, but yeah.
Can I ask,
You
you
said
said
it
you
was
had 4 surgeries.
I did.
How effective are they?
I highly recommend them. I will tell you, they were horrible. It was as much pain as delivering my son who ripped me, but the problem was that she didn't send me to pelvic floor therapy, so we didn't manage the pressure, we didn't manage the lack of range of motion in my pelvic floor. She also missed, I had a suspensory ligament that was damaged when I tore that she missed. And so I literally was 8 weeks post-surgery and I could already feel it coming back. So if you don't deal with what caused it, you may not outlive needing a second surgery. And I didn't want another one. What they do is the tissue becomes thin, okay? So when your rectum is coming into your vagina, the vagina becomes thin. So the stool's pushing into the vagina. So what they do is they take the thin tissue out. So they just cut this big opening and then they sew it back up. And so I don't know how many of those they can do. Do you know what I mean? Like, I didn't want number 2 because number 1 was awful enough. So, but it was very, I mean, I had really good sexual function and I didn't, my peeing came back for a little while, it got worse, but then it got better. I mean, if you have things that are hanging outside of your body, I highly recommend it. Yeah. You have one.
Oh, I just have a comment. When I was living in the DC area, I was having a lot of back problems, and my back doctor sent me to a pelvic floor. She was a registered nurse that worked in with cancer doctors, and it really helped.
Yeah, I have a lot of patients that come to me for back pain, and I even had a young man, and he was just miserable. When I evaluated him, I knew it was going to be a pelvic floor problem, and he was a young man, and there is no way a young man's going to be like open to that. And so I just kind of like breached the topic at the first visit, and I'm like, we're going to try everything, but I really think this is where we're going to end up. And so I just want to open that door for you to be thinking about. And eventually we got to that door, and he was very reluctant, and you know, it has to be okay, you know, I'm not pushing it on him, but he was so much better that the next time he came back and he was kind of like, can we do that again? So it's a different kind of therapy, and it works really good.
I feel like I've talked through questions, so I'm reluctant to ask if anyone else has a question.
You might have questions somebody else doesn't want to ask.
Yeah, maybe, but it's actually more about, so if you, I don't know if it's asymptomatic or not, but if you don't have incontinence, you don't have any parts hanging out of your body, but you have pain with prolonged standing or walking,
Very likely.
I'm just wondering about things like if, you know, and presuming that insurance is not going to pay, and kind of regardless, I'm just wondering about, like, I'm sure you can't give me a number of visits.
Okay, so it's
kind of a range.
So I usually will tell people on their first visit, depending on what I find. Sometimes I get inside and there are so many trigger points and so much that it's going to be a lot.
Yeah.
But I would say for the average person, you should be able to get from start to finish in 8 to 12 visits, depending on
I was
what.
going to say it ranges.
Yeah, 8 to 12. It's very common, because so many of us are cash-based practices, it's very common for us to kind of work with you where you're at. So if, you know, like I have some patients that I'm like, if you don't come see me twice a week, you're undoing everything that I'm doing. So they're that bad. But most people, you know, we have wands, we have some different tools that you can kind of use to help deal with your trigger points in between visits, and we can teach you how to do that. I try to see patients once a week for the first 3-ish weeks, depending on what you look like and what your pain is like. And then we try to go to like once every 2 weeks, because a lot of it is, I just give you the tools and you go home and use them. And you have to do the exercise enough to affect the tissue to be ready to move to the next thing. And so once we get you pretty solidly on a home program, and I know that you're doing it right, I might send you away for 2 weeks, and then eventually I might send you away for 3 weeks, and then eventually I might send you away for 4 weeks. So those 12 visits are usually over at least a 6-month period. Yeah.
Thank you, Lauralee. That was Are you available in case people want to come up to you right now with private questions? Okay, thank you, everyone. Thank you so much.
You too.
You bet.